All right, good afternoon. Thank you all for coming. I know how tempting that weather is out there in that pool, so I do appreciate you joining to listen to this talk. I wanted to, before I move on, again, my financial disclosures. And my objectives for this afternoon really reviewing two contemporary issues in colorectal cancer. The first one being COVID-19 and how it's affected our practice. The second being a deeper dive into early onset colorectal cancer, which Dr. May highlighted several important points earlier today. So our objectives really to review the current state of COVID-19, potential implications for colorectal cancer outcomes, evaluate some real-world data on the effect of COVID-19 and CRC and some lessons we've learned, discuss the epidemiology of early onset CRC and some recent updates to the screening guidelines, and then share a framework for future research in this area. So as of today, there are over 160 million cases of COVID-19 worldwide and over 3 million deaths that have occurred as a result. Thankfully, vaccinations are on the rise as well, which is great news. Certainly, when we look at sort of those graphs of infections to vaccinations to date, we see sort of almost a mirror image of where we were starting earlier this year, which is encouraging. But certainly, this disease has had a devastating toll here in the United States as well as globally. Earlier on, when we were paying really close attention to mortality and how it affected racial ethnic minority groups, we noticed pretty early that Black, Indigenous, Latino, and Pacific Islander populations were 2 to 2.6 times more likely to die of COVID-19 compared to white populations. More recently, this data is not being tracked as closely now that we have vaccinations and we're sort of seeing that death count decline. But even so, when we look at infections, this is more recent data from the Washington, D.C. area, you see that, for residents in Washington, D.C., their infection rates, and this is as late of May 2021, 82% of the folks who are infected in the D.C. area are Black compared to 9% who are white. And so just because we're no longer closely tracking this information certainly does not mean that it's resolved or that it's not an ongoing issue. When we also look at vaccination distribution, we also know that there are inequities there as well, with Asian and white populations being almost 2 to 3 times more likely to be vaccinated compared to Black and Hispanic populations. So when COVID-19 sort of first emerged, the evidence of, or the presence of gastrointestinal symptoms was really quite novel. And in this brief communication presented by Zhao et al., they commented on about 20% of individuals who presented solely with GI symptoms. In fact, this made headline news when a woman who had no respiratory symptoms but just had nausea and vomiting presented and was diagnosed with COVID-19. And in fact, Dr. Ned Sharpless, who leads NCI, had penned an editorial sort of early on in the course of the pandemic, highlighting what he thought would be the outcome or the impact of COVID-19 on cancers, relevant to us, colorectal cancer in specific, which I'll get into more detail about. So what were the sort of initial estimated impacts of COVID-19 on colorectal cancer? We saw early on a significant reduction in diagnostic tests related to cancer detection and prevention. So you see here mammograms decreased by about 87%, pap smears by 83%, and colonoscopy significantly by 90%. And this was comparing data from February of 2020 to data from February of 2019. At the same time, there were estimates that there would be close to over 22 million screening tests for the 5 most common cancers would be disrupted, leading to delayed or potentially misdiagnoses for over 80,000 patients. Of those, about 19,000 were thought to be colorectal cancers that would be either delayed or missed. And in this editorial, I mentioned that Ned Sharpless penned, NCI sort of using modeling data, estimated that by 2030, so over a 10-year period, there would be an additional 4,500 excess deaths due to delays related to COVID-19. What have we observed, though? So here I'm showing you some data from the San Francisco Health Network, so that's a safety net health system. Based in San Francisco, and here what I'm showing you is on March 5th, we have the very first case of COVID-19 that's diagnosed in San Francisco. And right around that time, you see this precipitous decline in FIT and in colonoscopy. So between the sort of beginning of March through the end of March, there was an 85 to 90% decrease in colon cancer screening tests within that health system. Around the same time, they observed a significant increase in telehealth use. And so in a health system that only used to use about 5% telehealth services, there was about an 80% corresponding increase in the use of telemedicine services. And not Zoom, but truly just telephone visits. Here I'm showing you some data from our own health system in Seattle. So this is looking at data from the Seattle Cancer Care Alliance, which is an NCI-designated cancer center, as well as Harborview Medical Center, which is our safety net system in Seattle. And we looked at individuals who had scheduled GI procedures between March 18th of 2020 through May 18th of 2020. And that really was meant to correspond with when the Surgeon General had sort of gave recommendation and guidance to stop doing elective procedures. That was soon followed by similar recommendations from the GI societies. So what you see here is that initially there were about 748 procedures scheduled during that time, and about 480 of them were delayed due to COVID-19 guidance. 268 remained on and were completed, and those were thought to be more emergent cases that needed to be completed. When we examined our data by the end of last year, we found that 54% of those who had had delayed procedures had yet to return to complete their endoscopic procedure. Of those that did return, 5.4% were diagnosed with GI cancers, and this included colorectal cancers, pancreatic cancers, and stomach cancers. We found about 10% of individuals had actually checked into emergency departments during this time period related to their symptoms, and a few of these cancers were actually diagnosed after they had been hospitalized for presenting with these GI symptoms. When we sort of took a deeper dive in this data looking at what types of procedures were delayed, as you can imagine, almost half of them were colonoscopies, for colorectal cancer screening being the primary indication, followed closely by EGDs, and then those who were getting EGD and colonoscopies really to evaluate obscure causes of bleeding. We then looked at time from when they initially delayed their procedure to return for completion. And overall, took about a median of 88 days, ranging from 63 to 120 days for folks to return once their initial procedure was canceled, but there was no difference that we observed based on the procedure type. Here I'm showing you some healthcare data from around the country, and this was using a large conglomerate data set that represents several practices along the East Coast. And what Con and all did is that they looked at a time period of March to July of 2019, and then they compared that to July and November of 2020. And then they also did some additional sort of sensitivity analyses where they compared all of these values to 2017-18 data. And pretty much the take-home point here is that when you look at upper GI endoscopies, you see about a 70% decrease. Colonoscopies, again, about an 80% decrease. Abdominal ultrasounds declined by about 40%. And then at the same time, when you look at new diagnoses of GI cancers, sort of this image here on the right, again, you see a decrease in esophageal and gastric cancers by about 10 to 15%. And then you also see decreases in pancreatic, gallbladder, bile cancers, et cetera. But again, really the significant and what, the most impressive finding, again, is that significant decrease in colorectal cancer. Interestingly, when they looked at this data from July to November of 2020 and then compared it to that same time period earlier in the year, there's some improvement. And so, you go up from about 23 cases to now 27 cases per 100,000 patients as far as the diagnosis being made. And so sort of suggesting that, we're rising, but not quite where we were before. And even when you look at data right now, across most healthcare systems, we're still about 25% behind where we were before COVID-19. Here I show some data from Dr. May's group where they looked at individuals and sort of the ways that they were screening prior to COVID-19 cessation, during the period of cessation, again, due to guidance coming from national and societal groups, and then looked at a period after cessation as well to see if individuals had recovered and were screening in the same ways that they had before. So the main findings that they demonstrate here is that when it comes to FIT, so again, before guidance to stop screening, you see a significant decrease in the use of FIT, but interestingly, that after cessation, that sort of FIT use almost rebounds and is slightly even higher than prior to the period of cessation. You see similar declines in colonoscopy use, but unfortunately that increase, even though it's improving, again, not quite where we were prior to COVID-19. And then when you look at all modalities combined, again, the significant decline during the initial peak of COVID-19, and now in the gray bar showing improvement, but again, not yet back to baseline. So what are some lessons we've learned from this experience? So, myself, Dr. May, and others, wrote very early in the pandemic about how we were concerned about how the pandemic would likely exacerbate persistent colorectal cancer disparities. We postulated that, the decreases in screening participation would be more especially pronounced in federally qualified health centers and community health centers and other areas of limited resources. We were concerned about the delays in follow-up of abnormal stool-based tests, which we've, sort of talked about extensively about the importance of this. We were concerned about limited community-based relationships and partnerships that could expand and progress research. And we're also concerned about the limited opportunities for community engagement and advocacy during this time. We offered several potential solutions that individuals and practices could consider, including increased use of non-invasive screening modalities, using sort of mailed FIT outreach programs, identifying gastroenterology partners that private and community groups could work with, and some other potential solutions as well to mitigate some of those disparities. And then in this work, this was a work from my group that we published recently, and what we did was sort of took a 3-year outlook on what the impact the pandemic might have on CRC outcomes. We modeled 4 different scenarios. Scenario 1 is sort of the baseline is sort of if everything would have happened as it would. Scenario 1 shows, again, this period where things are good in Q1 of 2020, and then we stop everything for about 3 months. But in Scenario 1, we kind of have a prolonged period of reduced screening, again, due to a combination of factors, including patients' desire to not want to come in, wanting to wait until they're fully vaccinated, having backlogs, et cetera. Scenario 2, you sort of have a longer period where we have reduced screening, and then we resume at a 75% capacity in 2022. And then in scenarios 3 and 4, you have mirror images of scenarios 1 and 2, but we increase FIT from about 15% to 21%. And what we demonstrated was essentially by doing this, you could improve screening in almost 250,000 individuals, detecting an additional 3,000 colorectal cancers, the majority of which would all be early stage. And so just this really small increase in FIT use during this time could make substantial differences. And here's just sort of an image sort of depicting the number of cancers that would be detected during this time and the proportion of those that would be early stage. And again, just highlighting that in scenarios 3 and 4, you end up screening more people, you detect more early stage cancers than if you would have done nothing in response to the pandemic. So the key messages that I want you to take from this portion is that COVID-19's impact has been global, with inequitable outcomes, including in vaccinations, that it's challenged GI patient care from management of infections, related symptoms to endoscopic practice. Declines in endoscopy were projected earlier on to adversely impact colorectal cancer, and so far the real-world data seems to be accurate and mirroring that, but time will tell more, especially because colorectal cancer is a disease that takes many years to completely come into fruition. And, as we sort of suspected and as we are already seeing, COVID-19 will likely exacerbate existing GI disease disparities. But proactive measures like increasing use of evidence-based interventions and tailored efforts to minimize losses to follow-up are needed and could potentially offset some of these harms. Next, I'm going to pivot for the next 10 minutes and talk about early onset colorectal cancer. So as Dr. May introduced you all to this, we know that the landscape of colorectal cancer is changing, whereas today 1 in 10 people who are diagnosed with colorectal cancer is under the age of 50. And in this 2018 survey of about 1,200 patients, 72% of those diagnosed reported having no family history of colorectal cancer and were in fact diagnosed with later stage disease, stage 3 or 4 disease. In this paper that was published in JAMA earlier this year, the authors postulate that by the year 2040, I want you to focus on the dark blue dots here, that by the year 2040, that those who are under 50, the number one cause of estimated deaths from cancers in this group will be colorectal cancer, which really, sort of leads us to, want to focus attention on this disease and how we can better intervene on those who are under the age of 50. So Dr. May presented some of the data from the USPSTF. Here I just want to highlight 3 images from this updated guidance. Based on the different modeling scenarios, what the authors present here is the estimated life years gained per 1,000 individuals screened. And the lighter green here is showing you what those numbers are for those who are 50 years and above. And then the darker green is showing you here what would happen if you started screening at 45. So essentially by, starting screening at 45 by all of these stool-based tests as well as direct visualization tests, you're able to add anywhere between 22 to 27 additional life years gained by starting screening at 45 rather than waiting until 50. And that should make sense because, younger people, if we're able to catch cancers earlier, then the overall benefit of survival is improved. And because they are younger, they're more likely to sort of live a life in which they thrive more than somebody who may potentially be older and may have more comorbidities. In the second image, here we're talking about the estimated number of cancers, colorectal cancers that are averted. And I want you to notice that this number is significantly smaller. So by starting screening at 45, you're really only averting anywhere from 2 to 3 cancers compared to those who are, who are over the age of 50. And then finally, this is looking at the number of deaths you would have averted if you start screening at 45. And again, I want you to observe that these numbers are much lower if you start at 45. So anywhere, usually around 1 death averted by starting screening earlier. I won't go into detail, just to kind of again highlight that the USPSTF has now given a grade B recommendation to screening individuals for colorectal cancer between the ages of 45 and 49, which makes a significant difference as far as insurance coverage. So briefly, we all know that certainly colon cancer most frequently occurs between the ages of 65 and 74. And in fact, the average age at diagnosis is 67, with the average age at death being 72. And when we look at the effect of colorectal cancer screening over time, starting in 1975 until more present, you can see that for those 55 and older, that the overall incidence as well as this is incidence has overall declined significantly, with steep declines once you reach 70 to 74. As I present the story, I do want you to notice that the numbers on these axes changes. And so when we're looking at 55 to 59, we're looking at 0 to 100 per 100,000. When we're looking at older age groups, we're all the way up to 250 per 100,000. Now, if I show you this data for the young adults, these numbers are really quite small. And so even though we see this trend in that upward direction for those who are between the ages of 20 to 54, keep in mind that these absolute numbers are really, really quite small. I don't want to discount, though, that colon cancer incidence in this group has been increasing by 2.2% since the early 1990s. And so certainly this is an issue that is worth discussing. Again, here just showing the absolute incidence of colorectal cancer under 50 is low. So when we look at starting at the bottom of this table, for those who are 70 to 79, when we look at overall their rate incidence between 1984 and 1988, we see that it's about 356 per 100,000, which is overall a decrease of about 46%. But this number is pretty significant. It's about 166 per 100,000 in the population as far as an absolute difference. When we look at those who are 20 to 29, while that relative change is really impressive, again, that 125%, this really only amounts to about 1 person per 100,000 in the population. We know that when we look at CRC incidence in those under 50 by geography, that there are significant differences. It's almost as if you could draw a line between the eastern and western parts of this country, and you see that the incidence is much higher in the eastern part of the country compared to the west. Several hypotheses have been generated for this related to environmental exposures, water health quality, antibiotics in foods, etc. And again, highlighting that this increased incidence is really pronounced in those who were born after 1960, where you see this exponential rise for every year since their birth. Again, sort of speaking to some sort of temporal relation between exposures for those who were born in 1960 and beyond. We know that in general, colorectal cancer mortality is highest in Black Americans. When we look at younger individuals, however, while there are still, so here in this dark blue line, we're looking at all colorectal cancer amongst Black people, which is about 12.7 per 100,000. And then here is in white people, about 11. And so even though there's still a difference between Black and white under young onset colorectal cancer, the difference is not as pronounced as when we look at all age comers. Specifically, when we looked at rectal cancer, which is where we tend to see most of the early onset colorectal cancer, you see that the incidence is actually higher in white patients than it is in Black. So take-home points from this. Despite the relatively lower risk, CRC in those under 50 has increased by about 2.2% per year since the early 1990s. People born in and after the 1960s are at higher risk of CRC compared to older generations. And in young onset, so again, that 20 to 49, Black-white incidence disparities have increased between 1992 and 96 compared to 2010 and 2014, but that mortality gap between whites and Blacks still persists. Briefly, just wanted to review some of the pathogenesis. What you're looking at here is, germline mutations for colorectal cancer for those who are under the age of 50 compared to those who are over 50. And what you can see here is that for those under 50, 80% have no germline mutation. So about 10% less than those who are over the age of 50. Here I'm showing you that a higher proportion of colorectal cancer under 50 have later stage disease. And so in this study by Andrea Burnett-Hartman et al., they look at individuals who have early onset colorectal cancer compared to late stage. And what you can see is that for those in early onset, 34% and 26% have stage 3 and 4 disease approximately, compared to 26% and 17% for those who have late onset disease. And then again, we can see that the rate of rectal cancer in this population is much higher than those who are over the age of 50. And this is after they adjusted for potentially confounding variables, including smoking, health insurance access, race, ethnicity, sex, BMI, and comorbidity score. What are some of the potential factors, risk factors associated with early onset colorectal cancer? So we think the harmful risk factors may be obesity, so potentially through metabolic syndrome and insulin resistance, smoking, through known exposures that are carcinogenic, alcohol, red or processed meats, and antibiotics. And the antibiotic story is really interesting. So there's almost like this increased use of antibiotics in foods right around the 1960s, and that also tends to be when you see that increase happening with that birth cohort. And then as far as the protective factors, we believe those are aspirin, NSAIDs, because they can inhibit cyclooxygenase activity, and then physical activity. So just briefly again, the majority of colorectal cancers diagnosed under 50 have no germline mutations on multi-gene panel testing. Up to 26% of adults who are under 50 with colorectal cancer are diagnosed with metastatic disease, compared to 17% of those who are 50 years or older. And then again, because of the birth cohort effects, we may need to study the risk factors across a lifetime rather than just risk factors in the few years before diagnosis. And I really think in the future where this is going is, again, needing to study these risk factors over an individual's life. And so looking at age of smoke initiation and the duration of which people might have been exposed to tobacco, looking at their birth weight and childhood obesity, and not just their current weight and obesity now, looking at antibiotic use in infancy or in childhood, and then also looking at the age and duration of occupational and environmental exposure, such as mineral dust and plastics. And there are several groups who are currently around the country who are seriously looking into this, and so hopefully we'll have more information in the years to come. But I want to thank you for your attention, and I will take any questions.
There we go. So we focus a lot as gastroenterologists on quality indicators for endoscopy, adenoma detection rate, quality of the prep, things that we have control over. But we have our colleagues in primary care who are sending patients in or sending fit tests either programmatically or from their offices as just good practice. And I wondered what you think an indicator of a good either practice or a healthcare system. What kind of an indicator would you say, or what's the number for fit positive presenting for actual colonoscopy?
So the U.S. Multi-Society Task Force released their document a few years ago now, and what they recommended was that 80% of individuals with an abnormal fecal immunochemical test ultimately go on to complete a colonoscopy. There are very few health systems in this country that have achieved that goal. So we know, for instance, the Kaiser Permanente Northern and Southern California health systems have achieved that goal. The KP, what's now KP Washington, is close to that. But in our own work, when we, and I tend to do research within safety net health systems, our numbers are closer to 50%. So I think 80% is, it is aspirational and what we should be hoping to achieve. But when we look, there are individuals who should never have been fit tested to begin with, right? And so in our prior work, we show that up to 10% of individuals who receive a fit who are positive should have never received it. And then there are those who decline as well. And so if you take those numbers combined, then that likely is 20%. So yes, 80% is what we should strive for. It is aspirational. It takes multiple interventions at different levels of care in order to achieve that goal.
I was very taken by both of your talks today and at the CEDARS conference a few months or weeks ago. My question is, we never talk about pesticides when it comes to this. You talk about the antibiotics and water and this and that, but this is the time when industrialization of farming in the United States took place, and the kid that's being rolled around jumping on Cheerios, what's in that Cheerios? What is it that causes cancer in the 30s? It's got to be something that the little kid was doing. You mentioned childhood obesity, and maybe that's, and now you're seeing the 30-year-old that's all thin and fit, and you think, well, it's not obesity, but nobody's talking about the pesticides and the industrialization of farming that I've seen, and I wonder if you have any comments on that.
Yeah, I mean, I show that map of the United States because it's really, kind of remarkable to see that difference between the eastern part of the country and the western. And I think that certainly pesticides could play a role, right? Many of those states that fall right in middle America are the places where farming is happening and are some of the states that have potentially less strict regulations around pesticide use and, sort of tracking exposure. So for those who are investigating this area, I think absolutely digging back to what sort of pesticides are being used and what are children being exposed to that could potentially support why we see this birth cohort effect is really important.
Specifically, I mentioned Cheerios because of the whole Monsanto and Roundup and all that stuff. And I don't know if that specific case has been expanded.
Cheerios? Is that what you said?
Anything that involves Roundup and the whole...
Oh. Nothing that I've seen that specifically makes that connection.
There's a list of like 90 things that my kids eat that have.
That's a good question. So there's a question, I think you answered it with your slides, but maybe it bears going over with again. The question is, what is the prevalence of genes that contain pathologic variants in people diagnosed with colon cancer less than 50? So the early onset colorectal cancer, I think you showed the pie graphs, but just to
Yeah.
go over that again.
Yeah, so as I mentioned, only 20% of those who are under 50 will actually have a pathogenic kind of variant that can be explained on gene testing. So the majority of them do not have any mutation that could explain that finding.
And maybe they were specifically getting at, is it more commonly Lynch or less commonly Lynch versus?
The Lynch prevalence in young onset and adult onset, at least the slides that I showed, it's comparable. There are other genes that have just not been well defined yet. So there's the sort of variants of unknown significance tend to be a little bit higher in the under 50 compared to over 50.
I have one question, Rachel. So, in your experience, and Fola mentioned this earlier, we need to start educating people, getting them prepared for their, once they're in their 40s to get screened. In your experience, what do you suggest as a good educational strategy to kind of overcome not just disparities, but any barriers we have for younger people to start thinking that it's time for you to start taking care of your health and be prepared to get screened?
I think having family discussions is really important. So there's data, for instance, that shows that Black people are less likely to know their family history compared to white individuals. And because we know of the strong association between family history and that risk association with colorectal cancer, encouraging people to start having these conversations really early, as young as elementary school, I think would be really helpful. When we talk about pipeline programs, that's certainly a huge part of that, because if we can educate younger generations to start thinking about this, then they can have those conversations with their families in a much more open and frank way than has been done in the past. For many of my patients, I'll give you an example of a young person who I saw in his 30s, whose father had been diagnosed with colorectal cancer when he was 40, but had no idea. So because, the father was diagnosed at 40, he should have begun screening prior to the time he even saw me.
Mm-hmm.
But we see this over and over and again, especially in my SCCA clinical practice, which is the oncology setting. So I think if we emphasized family conversations earlier, we could potentially have people know earlier and begin the process when they should.
Great. Thank you.
Okay,
Thank
you.
you.
So much,
Thank
Rachel.
you so
Thank
much.
you.
It's Tony. Okay, by popular demand, I think we have Tony Limbo live. Can we get Tony on the line here? Standing by for Boston. Tony, I can see you. I cannot hear you yet.
Hear me? Can you hear me now?
We can hear you now. We can hear you now. We can hear
Oh,
you
great.
now. We can hear.
Well, thank you, and I apologize for the sound quality on my previous talk.
I think we're going to cut this mic. We're going to cut this mic. We're going to cut this mic. Okay, Tony, if you can hear me, we're ready for you. We've got your slides up.
Are you ready? Can you see my slides and hear me okay, Gary?
Yes.
Yes.